All right, boys and girls. So let's start with the new topic, which is orbital cellulitis. What is orbital cellulitis? Orbital cellulitis is inflammation of the intraorbital contents. Yes, but before moving on to orbital cellulitis directly, as I always say in my class, if you know the basic anatomy, the signs and symptoms become a cakewalk for you. So before going on for orbital cellulitis, it is important to understand what is your superior orbital fissure. Yes, so superior orbital fissure is a gap which consists of two boundaries, which is greater wing of sphenoid and lesser wing of sphenoid. I'm just going to show it to you. So check out the video of the skull. So are you able to appreciate? Can you see that there is superior orbital fissure? Are you able to appreciate? So this is your superior orbital fissure. So sphenoid has got three parts: the central body, the peripheral wings, then there is lesser wing and greater wing. Can you appreciate? So this is your greater wing, yes, and this is your lesser wing. So the gap between lesser wing and greater wing of sphenoid is superior orbital fissure. Now, are you able to appreciate? So this is your lesser wing of sphenoid and this is your greater wing of sphenoid. So this is your superior orbital fissure. Yes. Now, what are the structures that pass through the superior orbital fissure? So basically, you divide superior orbital fissure into three parts: the superior part, the middle part, and the inferior part. I again repeat: superior part, middle part, and inferior part. And this is divided with the help of common tendinous ring. So what is the relevance of this common tendinous ring? It gives origin to the recti muscles. So you know what are recti muscles? So recti muscles are extraocular muscles. So we have got superior rectus, we have got medial rectus, we have got lateral rectus, and we have got inferior rectus. So here it will be superior rectus, here it will be medial rectus, here it will be inferior, and here it will be lateral rectus. Yes. Now this common tendinous ring divides the superior orbital fissure. This part is your superior part, this part is your middle part, and this part is your inferior part. Is it understandable? All right. Now, what are the structures that pass through superior part of superior orbital fissure? So remember LFT. LFT kara lo jaake. What is LFT? That is liver function test. Yes, but here we will use the mnemonic LFT to know, to remember, to understand the nerves which are passing through the superior part of superior orbital fissure. So L for lacrimal nerve, F for frontal nerve, T for trochlear nerve. So what is the purpose? So lacrimal nerve supplies the periorbital area or the lacrimal area. Frontal nerve supplies the frontal area, sensory nerve. Both of these are sensory nerve. T for trochlear nerve. Trochlear nerve supplies which muscle? Superior oblique muscle. Remember, SO4, LR6, RES3. Superior oblique is supplied by 4th cranial nerve, which is trochlear nerve. Lateral rectus is supplied by 6th cranial nerve, which is abduction nerve. And rest, the remaining extraocular muscle, the remaining 4 extraocular muscles are supplied by the oculomotor nerve. Yes. So LFT. And also we have got one vein which is exiting out from the superior part of superior orbital fissure, and one artery which is entering or exiting. It is also exiting out of the superior part of superior orbital fissure. As I always say, Shakespeare बोल के गए हैं क्या, नाम में क्या रखा है, बट ऑफ्थेल्मोलॉजी में नाम में ही तो सब कुछ रखा है. Okay, so what is the name of the vein? Superior ophthalmic vein, because it lies in superior part of superior orbital fissure, superior ophthalmic vein. What is the name of the artery? Recurrent meningeal branch of ophthalmic artery. Recurrent means back. Meningeal branch which supplies meninges of ophthalmic artery. Ophthalmic artery is of course the artery which lies in the orbit. So it also exits. So a recurrent meningeal branch, superior ophthalmic vein, they are going out of the orbit, while lacrimal nerve, frontal nerve, trochlear nerve, they are entering through the superior part of superior orbital fissure. Done? Alright, now coming on to middle part of superior orbital fissure. So one nerve which is entering is nasociliary nerve. Another nerve which is entering is abduction nerve, which supplies lateral rectus muscle. And third nerve is oculomotor nerve, which is third cranial nerve. Now I further divide oculomotor nerve into two branches. So one branch is your superior division, second branch is your inferior division. Now superior division of oculomotor nerve supplies two muscles. Which muscles? Which are superior. So one is LPS, levator palpebrae superioris, second is superior rectus. Inferior division supplies three muscles: inferior rectus, inferior oblique, and medial rectus. Is it understandable? All right. So we have done the structures passing through the superior part, the middle part, and now the inferior part. So inferior part, शेक्सपियर क्या बोल के गए थे? नाम में ही तो सब कुछ रखा है एक्चुअल में, बट शेक्सपियर बोल के गए थे नाम में कुछ नहीं रखा है ना. सो inferior ophthalmic vein which pass through inferior part of superior orbital fissure. Yes, I'm not writing much because I want to make this video very crisp and concise for the nth hour revision. Yes, so these are the structures which are passing through the superior orbital fissure. Now there is another structure which is your optic canal. So optic canal, again optic canal, optic. Which nerve passes? Optic nerve passes. Which artery passes? Don't say optic artery, say ophthalmic artery. So two structures which are passing. So that means all the structures which are passing into the orbit through the superior orbital fissure will lie inside the orbit, and all the structures which are passing through the optic canal into the orbit, it will also lie inside the orbit only. Yes, now having this knowledge, अगर ये knowledge आपको हो गई तो orbital cellulitis हलवा है बॉस, हलवा. चलो अब आते हैं orbital cellulitis की तरफ. Yes, now coming over to orbital cellulitis. Okay, so yes. So what is orbital cellulitis? Orbital cellulitis is your inflammation of the intraorbital soft tissue. So this is your orbit, this is your eyeball. If there is inflammation of the intraorbital soft tissue, call it as orbital cellulitis. Most common etiology, your 2 PYQs. Yes, which is the most common organism? Staph aureus is the most common organism causing orbital cellulitis. Which is the most common sinus which is involved? It is ethmoid sinus or ethmoid sinusitis. This is your FMG PYQ question. Yes, ethmoid sinusitis. Now what will be the features? You know, there are structures which are lying in the orbit. What are those structures? Which are passing through superior orbital fissure, which are passing through the optic canal. Of course, some structures also pass through inferior orbital fissure. Yes, okay. Now when there is inflammation inside the orbit, there will be raised intraorbital pressure because orbit has bony boundaries. Yes, the superior wall, the inferior wall, the medial wall, the lateral wall. So as a result, it will not allow the inflammation to spread sidewards or upwards or downwards. The only place where the inflammation can go is anteriorly, but anteriorly there is eyeball. So the inflammation is going to push the eyeball anteriorly such that there is going to be proptosis. Proptosis is protrusion of the eyeball because of raised intraorbital pressure. And when there is raised intraorbital pressure, it is going to compress all the structures which are present inside the orbit. What are those structures which are present inside the orbit? Sir, the same structures which are passing through the superior orbital fissure, optic canal, inferior orbital fissure. Yes, now what are those structures? LFT, lacrimal nerve, frontal nerve, trochlear nerve. So when the lacrimal nerve, frontal nerve, trochlear nerve is compressed, what will happen? Loss of sensation. Loss of sensation of which area, boys and girls? Say periorbital area. Yes, because this area is supplied by lacrimal nerve, periorbital area, frontal area. And what about the trochlear nerve? Superior oblique muscle paralysis. Yes, I told you na, this is how you clinically integrate the clinical subject with that of the basic sciences. All right, so loss of sensation will be there. LFT done. Okay. Now, second, what are the structures which are passing through the middle part of superior orbital fissure? Nasociliary nerve. Nasociliary nerve, boys and girls, it forms the afferent. Any reflex in the body has got two pathways, the afferent pathway and the efferent pathway. So nasociliary nerve forms the afferent of which reflex? Afferent of blink reflex. Yes. So blink reflex, you touch a cotton wisp at the temporal part of the cornea, there will be sudden blinking, or any sand particle goes into your eye, you suddenly blink now, because the nasociliary nerve forms the afferent and the facial nerve forms the efferent, because there is contraction of orbicularis oculi. Yes. So the blink reflex will go because due to compression of the structures in the orbit and simultaneously the nasociliary nerve, it will lead to demolish of the blink reflex. So nasociliary nerve will lead to the loss of blink reflex. So blink reflex will be gone. What about the abduction nerve? Abduction nerve supplies lateral rectus muscle. So lateral rectus muscle will go into paralysis. Remember, SO4, LR6, rest 3. Now coming over to oculomotor nerve. Yes, oculomotor nerve, superior division, inferior division. Superior division supplies levator palpebrae superioris, which will lead to drooping of the eyelid. Yes, and superior rectus, which is again extraocular muscle, it will go into paralysis. Inferior oblique, inferior rectus, and medial rectus. So all these extraocular muscles will get paralyzed. As a result, the eyeball will be fixed. There will be no movement of the eyeball. Is it understandable? Now, there are two veins, the superior ophthalmic vein and the inferior ophthalmic vein. Now, when the superior ophthalmic vein and inferior ophthalmic vein is compressed, so you know there is artery which is supplying the eye and there is vein which is draining the blood from the eye. Artery is a high pressure channel, vein is the low pressure channel. When there is external compression upon the artery and the vein, the one with the low internal pressure will get compressed first. That means the veins will get compressed first as compared to the artery. That means artery is pumping the blood, but vein is not able to drain the blood. As a result, the blood, extra blood which will get collected, will reflect upon the conjunctiva. What is this? This is your conjunctival chemosis and congestion. Conjunctival chemosis and congestion. Is it understandable? Conjunctival chemosis and congestion. What has happened to the pupil? Can you also appreciate the periorbital edema? There is periorbital edema. What is this? This is dilated and non-reacting pupil. Dilated and NR, non-reacting pupil. Why dilated and non-reacting pupil? Because again, when you show the light into the patient's eye, there is afferent pathway which is via optic nerve. There is efferent pathway which is via oculomotor nerve. When there is raised intraorbital pressure, all the structures passing through the superior orbital fissure and also through the optic canal will get compressed, and which is that important nerve passes through the optic canal, that is optic nerve. So optic nerve will also get compressed. So that means afferent is affected and oculomotor nerve is of course being compressed. The efferent is also affected. As a result, the pupil will not react to light. Yes, and along with it, there will be loss of vision. Why? Because the optic nerve is being compressed. Now there will be ischemia of optic nerve or pressure related damage of the optic nerve, leading to loss of vision. Yes, so these are the features that you see in orbital cellulitis, and along with it, because there is raised intraorbital pressure which is going to push the eyeball anteriorly, leading to proptosis, there will be intense pain. Pain will also be there. I am again saying that this is just for YouTube quick revision, so I am not writing much. I want to make this video very crisp and very concise and very conceptual. Yes, as you have done in my classes. All right, so this is about orbital cellulitis. Now coming over to one important thing which is also your previous year question, make a box, and which is the most deadly complication, which is the most deadly complication of orbital cellulitis. Now anywhere in the body If there is stasis of blood, it leads to formation of microclots, and you know there is cavernous sinus. Cavernous sinus receives the blood from where? It has got multiple tributaries, two of which are superior ophthalmic vein and inferior ophthalmic vein. Due to raised intraorbital pressure, there is compression of superior ophthalmic vein, inferior ophthalmic vein, which will lead to stasis of blood in these two veins, which will lead to formation of microclots, which will ultimately get into the cavernous sinus, leading to cavernous sinus thrombosis. This is the most deadly complication. Yes, अब now पहले बात सिर्फ लोकल एरिया तक थी, आंख तक, अब वो बात कहां तक पहुंच गई है? CNS तक पहुंच गई है. So there will be associated CNS signs and symptoms. Means मैं कौन हूं, मैं कहां हूं? Disorientation. There will be disorientation. There will be ataxia. There will be confusion, or the patient may even go into coma. The patient may even go into coma. Is it understandable? All right. Now, what will be the treatment of orbital cellulitis? I always tell that if you know the etiology, you also know the treatment. What is the etiology? Most common organism, infection, na? Staph aureus. Yes. And treatment will be antibiotics. Now, which antibiotic is effective against Staph aureus? One antibiotic, drug of choice. Don't say penicillin. In India, penicillin resistant Staph aureus are there. So you will go on for intravenous vancomycin. Intravenous vancomycin, single drug. If there are two options, yes, both A and B, or there is combination, so you go for vancomycin plus third generation cephalosporin. Yes, third generation cephalosporin. It is drug of choice for orbital cellulitis. What is the treatment of cavernous sinus thrombosis? Yes, for cavernous sinus thrombosis, if you know the etiology, what is this? There is thrombus. So you will give intravenous TPA, tissue plasminogen activator, and low molecular weight heparin. All right. Okay. Now, of course, there is another disease which is preseptal cellulitis, but for that you will have to attend my live lecture online or maybe in the class. So right now I am focusing only on the orbital cellulitis part, but there is one important PYQ which is related to cavernous sinus thrombosis. Yes, अब ये देखिए, ध्यान से देखिए इस इमेज को, कई बार देखी होगी, कहां पे? BD चौरसिया बुक में, है ना. अब देखिए, इफ देयर इज इन्वॉल्वमेंट ऑफ राइट आई लीडिंग टू राइट cavernous sinus thrombosis, now you are fearful that this cavernous sinus thrombosis, because there is communication between the cavernous sinus of right side and left side. Now you are fearful that this disease can spread from right side to left side. So one is you get MRI done, you will know. But in our country where nearly 80 crore people, they are dependent upon free ration from the government, would you want the patient to undergo MRI worth 10-15,000 rupees with contrast? Of course no, na. The patient may not come back because patient MRI नहीं करवाएगा, और patient बेचारे की न्यूज आ जाएगी कि डॉक्टर साहब, पेशेंट आपके पास ऑर्बिटल सेलुलाइटिस के साथ आया था एंड आपने MRI लिखा था एंड पेशेंट करवा नहीं पाया, तो बीमारी बढ़ गई. नाउ द पेशेंट इज नो मोर. दिस इज द वर्स्ट न्यूज दैट द डॉक्टर कैन हियर, राइट? सो आई ऑलवेज tell my students to be clinically so sound that you are not dependent on investigation. You use investigation only for confirmation purpose, not for diagnosis purpose. Yes, so if you are suspicious that the infection or the disease has moved from right side to the left side, so what you are going to do? Don't go for MRI. You just go on for simple test and you will know if the left side cavernous sinus is involved or not. For that you will have to focus on this image. Now, can you see one nerve which is unusual? Don't say, sir, oculomotor nerve, it is lying superiorly while other are lying inferior. No, there is one nerve which is unusual, abduction nerve, which is passing through the center of cavernous sinus. Yes, so you simply ask the patient to abduct the left eye. If the patient is able to abduct the left eye, that means the abduction nerve is intact. If the patient is not able to abduct the left eye, that means abduction nerve is involved. If there is involvement of the left cavernous sinus, the first structure to get involved is your abduction nerve, because it passes through the center of the cavernous sinus. Because it passes through the center of the cavernous sinus, yes, it will lead to paralysis of the lateral rectus muscle, and as a result the patient will not be able to abduct. So you will know कि अब बात जो है बढ़ चुकी है from the one side to the other side. Yes, so which is the earliest feature of involvement of other side of cavernous sinus? You call it as abduction defect of the other eye, sound eye, abduction defect of the sound eye, sound eye. Yes, so these are the few important things that you should know, but I had told you it will be like typical ophthalmology OPD type videos. I am going to show you, check out the patient. So I don't expect you to tell me the diagnosis, treatment, everything, but just focus upon the signs and symptoms that you see in the patient. This is the best way to understand and to imbibe what are the important points. Yes, now first and foremost you would see that there is periorbital edema, there is also drooping of the eyelid. Yes, okay, so I am taking the history. I'll skip the history channel, history part. Check this out. Now I am retracting the upper eyelid. Okay, now check this out. What you are going to see, check out the conjunctival congestion, check out the conjunctival chemosis, check out non-reacting, check out non-reacting mid-dilated pupil. And when I try to open it, auntie said, hi, that means there is pain. Why pain? Because raised intra-orbital pressure. Yes, okay, and all right, so these are the features. Yes, but the other eye is absolutely okay. The other eye is moving, but the right eye is fixed. There is proptosis, है ना? Okay, all right, all right. So this was our orbital cellulitis patient which you have seen. And can you tell me one more question? What is the most common cause of proptosis in children? Can you tell me? Boys and girls, this is your orbital cellulitis. Okay, I am talking of unilateral proptosis. Can you tell me which is the most common cause of bilateral proptosis in children? It is neuroblastoma. It is neuroblastoma. For adults, I will not tell. Let's wait for the other video. Yes, and that is also your INI CT question. Most common cause of unilateral proptosis in adults and most common cause of bilateral proptosis in adults. You are welcome to give me the answer in the comment section. Comment में मुझे बताइएगा what is the most common unilateral and bilateral cause of proptosis in adults. बच्चों का I have told you. Yes, and you can follow my Telegram channel which is Ophthalmology by Dr. Manish Chhabra. Ophthalmology by Dr. Manish Chhabra. You can also follow me on Instagram where I keep on doing rule of two diagnosis. Yes, I give you 2 points of etiology, of maybe the pathogenesis or clinical feature. Then I expect you to answer me with the diagnosis, or I can give you 2 points of maybe side effect of the drug, the mechanism of action. Then I'll expect you to answer me the name of the drug, है ना? So this is my Insta handle I_Manish, and this is the Telegram channel, right? And do follow and let me know how you are finding these videos, and I'll be coming up with more videos. And in case you want any specific topic, let me know. I am always and always here for you. So bye bye, ciao, and I hope to see you soon. मिलते रहेंगे. Take care. Love to all of you.